everyone, welcome to our podcast on AI in pathology, opportunities, and reality. I am Dr. Deepa, your podcast host for today, and I am the co founder and head of the Global Ambassador Program in PathIQ and the founder and academic director of Dr. Deepa's Learning Launch. It's my absolute pleasure to introduce our distinguished guest today, Professor Dr. Srinivas Chakravarti, sir, an internationally respected expert whose career has been dedicated to advancing laboratory medicine, transplant immunology, and molecular diagnostics and quality in healthcare. Over 30 years of experience is what he holds, and he has been a forefront in transforming laboratory medicine right across India. He has served in several prestigious leadership roles, which includes Director of Laboratory Medicine, Head of Transplant Immunology and Molecular Diagnostics, and Director of Center of Excellence for Phlebotomy AI. His expertise in quality systems is reflected by his role as ISO 15189 assessor, NABH QCI medical laboratory lead assessor, and CAP accreditation program inspector. And he's also a WHO trainer for good laboratory practice and laboratory quality management. Many in the laboratory community know him as the father of urine automation in India, a recognition which is for his pioneering work in modernizing urine diagnostics and improving the laboratory efficiency right across the country. Equally remarkable is his passion in teaching. An inspiring mentor and educator who has been honored with multiple Best Teacher awards and has guided countless students and residents and laboratory professionals right through their career. His academic journey is extensive, and he has authored more than 55 scientific publications and has been invited in more than 17 international conferences, and the count is still going on. His research interests are hematology, laboratory medicine, transplant immunology, immunogenetics, molecular diagnostics, laboratory quality management, patient safety, and risk management. Today, we are honored to have the opportunity to learn from this remarkable journey and hear his insights on artificial intelligence in pathology. Sir, it is a privilege to have you with us. Thank you for joining us today.
Hello, and I would like to thank you, Dr. Deepa, for giving an opportunity to just have a discussion about what's new in pathology. And the new thing is the artificial intelligence itself. Thank you so much for introducing me on a very big note. And I'm very honored to be part of your learning launch also.
Thank you, sir. Thank you very much. So artificial intelligence has rapidly become one of the most transformative developments in modern medicine. Radio diagnosis by far has adopted it earlier, and we are a little behind, but we are still catching up. So it has generated tremendous excitement and has a potential to enhance diagnostic, improve efficiency, and advance patient care. At the same time, it also has raised some important questions about its capabilities, limitations, some ethical considerations that need to be considered, and how it can be integrated safely into the clinical practice. To set the stage for our discussion, let's begin with a broader picture. Over the last few years, generative AI has entered almost every profession. How has generative AI, particularly to tools like ChatGPT, which is commonly used by the latest generation and other large language models, changed the way the pathologists work? Beyond simply saving time, where do you think these tools have added greatest value in our day-to-day practice?
Okay, so let us first understand that pathology is basically comprised of numerical data and morphological data itself. So we have a numerical data which is quantitative, and we have an image, or you call a morphology of any of the cells or the cell cast or whatever we are talking in the morphology, which has to be converted to quantitative analysis too. So we require a platform where we can have a quantitative analysis, standardization, which can happen in the pathology, which we all know that it is very difficult. So with the presence of this artificial intelligence, where we are calling about the generative AI and the large language models, which we call as LLM, like ChatGPTs and Claude, had shifted the concept of the qualitative to quantitatives itself. That is, it is trying to synthesize the intelligence, what you have given it to those machines, and getting onto the reporting itself. By this perspective, what we know is that there's a drift in your reporting formats itself. So what is happening? Your checklist, what you have got for a peripheral smear or a urine analysis, or it could be a microscopic analysis of any of the pap smears, or a cytology, or it could be a tissue diagnosis becomes very easy. Your long descriptions, what you usually give for the morphology, can be automated. And you are maybe having a report to say that I have viewed this slide and I have viewed the quantitative data. This is the report what I have generated, whether it is okay to see this. So there it comes, the massive volumes, what you would need to review every day gets refined to very minimum and only on what we call as the most complex ones will be thrown out for your review itself. So I think the impact of the generative AI and the LLMs will be in this context, where you have to dwell more upon the complex views as well as the complex data what you have got to become a consultant to the consultant itself. This is what my view is.
Great perspective, sir. AI by far is not only changing the clinical practice, it is also changing how we learn. Since you are an educator with a lot of experience, how do you see AI influencing pathology education and resident training over the next decade? Because that is the major change that's going to happen soon. Do you think the fundamental change will be in the way we teach or the way they decipher?
Okay, so let us take now our mobile phones, which we are all used to. Am I right? So when the mobile phones was introduced, we were having a text and talk mobile, and we were very happy. Then came smartphones. Then came whole bunch of apps, which made your life easy and making sure that all the ancillary gadgets in your home are put into your smartphones. Am I right? So now teaching also will become like that. The teaching is going to be like this. We all know that as a morphologist, when we have trained, we are being trained with multi-headed microscopes. And we require a pointer to show where the abnormality is, where the mitosis is, how do I count the mitosis, how do I see that this cell is malignant, right? So what happens when adopt AI to generate how you have to use which are the hot maps or what is called as a heat maps. Where is the pathology where you have to concentrate much upon, and the teaching becomes very easy and smooth and standardized. If you have a group of about 10 people viewing a slide, all the 10 people can view the same area, same point, same cell at the same time. But when you are having these regular 10 headed or 2 headed eyepieces, when you're going to see into the microscope, the viewer may be having some sort of myths or assumption that, oh, he's saying this, oh, he's meaning this. So the assumption was taking a hit. Now, with the adaptation in AI in teaching becomes more standardized, modular. That is what I mean to say that it is standardized. Whoever be in the teaching module, it becomes okay. Now come to the undergraduate teaching. In the undergraduate teaching, we have been taught the routine set of slides, which we usually get as one of the pathological markers. So that can be automated. So there is no need to worry about who is going today as a supervisor, whether it is an A category, B category, or C category. The modules becomes the modular teaching becomes the dissemination, the information becomes uniform. That is how the pathology education and training is going to be. In addition, today we all know that there is a gap between certain divisions in the pathology. So, for example, hematology, you have only a small amount of posting. Coagulation lab, we have a small amount of posting. Clinical path, where we require some information. So instead of you getting the training in silos, it will become a combo now. You're going to get the data when you're seeing a peripheral smear, you have histogram, you have scatter plot, you have got flow cytometry data. You also come to know that imaging there, your collaboration, so that the person will be able to get a perspective of a patient-centric laboratory medicine rather than just morphology. That's how the training will change.
Understood, sir. One of the biggest promises that AI is doing that it would improve diagnostic consistency is what it is betting on. So, can AI genuinely reduce the diagnostic errors and inter-observer variability in a laboratory perspective? If yes, how do you think it achieves this?
definitely the errors can be reduced. So what we talk today about the laboratory data, any laboratory could be even at the international level, which we call Mayo Clinic or any of the Stanford universities. All laboratories do have errors every day. But the benchmark should be maintained so that the error rate should not exceed, say, 3.5% or 4% on a benchmark, what we say the Q probe essay of the cap. Now, how can Indian laboratories achieve this or global laboratories achieve this minimum error rates? You automate certain mundane works. So now you have some auto verification, which is one of the greatest tool now today in the laboratory information software. Similarly, in pathology, you can make sure that if it is normal, it can get signed off. Okay. And once the data has been reviewed by the AI, like digital imaging systems, what to adapt, and there is an information software system which is going to view it and is going to say that, okay, this is a normal format. It comes only for you to say that this slide is only normal. Now, suppose you have a true cut biopsy where only a scanty population of the cells, say about 20 cells in one of the edge corner is there, and it is cryptic when you are viewing, your eye fatigue can be removed by adaptation of the AI itself. So that you become cautious when you are reporting a complex cases, challenging cases itself. In addition to this, what is happening in AI is that you have some literature review which you have to do before signing off any unusual case. The AI is going to integrate that data also, saying that how many cases worldwide has been reported, what are the clinical presentations, all those comes into the picture. So the error rates definitely is going to be reduced in the core clinical laboratories as well as in the histopathology too. Now, coming to that of the variability, I already told that since you have algorithms which you have going to be placing there in your laboratory information system along with the AI, the variability becomes very minimum. And this becomes machine learning for your system. So there will be an improvement in upcoming months where there is an institutionalized machine learning for your AI itself so that it comes to know that in this demography, this is very common. It's going to flag off there like that. So that's how the errors are going to be reduced. The variability will become uniform.
Thank you, sir. Actually, the auto verification has done a great deal of help in the corporate sector where healthcare checkups are very common. So the basic load of normal reports goes away from the pathologist to report, which is rightly said. Beyond diagnosis, pathology is increasing the treatment decisions also it helps. So what role do you think AI is playing in precision medicine and in personalized cancer therapy? How can AI help pathologists contribute more effectively to an individualized patient care?
Okay, let us take now oncology segment itself. So in the oncology, from the pathologist viewpoint, the morphology becomes very important. So the morphology today is not only restricted to a stained HNG slide, it also incorporates cytochemistries in some places. You require immunohistochemistry in most of the oncopathology cases. Suppose you have artificial intelligence which syncs with this and says that at the HND, the mitotic count is so much, which was subjective, becomes totally automated. Okay, becomes standardized. Next, suppose you want to view the membrane positivity in immunohistochemistry or cellular positivity in immunohistochemistry or a nuclear positivity in the immunohistochemistry. Say the stain is very weak, it can localize and say that so many cells are positive. Out of 100, 50 cells are going to be positive. So what has happened? The hidden perspectives, what you have got, the hidden predictive markers which are there to tell you the story, which can change the treatment is brought about by AI. That is one point. Second point is that for any of the tumors to get onto a discussion with the tumor board, and also with that of the personalized medicine, we require genomics or the molecular biology itself. Suppose you have molecular biology data which syncs in with your HND immunohistochemistry. You already have a risk prediction there itself. What therapies gets benefited to this and how you have to add. Now, recently I had been to one of the conferences where one of the reputed organization were talking about the computational pathology and how they have synced the integrated diagnostics of radio imaging to the histopathology itself. One of the advantages what the stalwart was saying is that by looking only at the HND and the cellular morphology, we can say whether molecular medicine testing is needed or not. Imagine a person is spending 60,000 rupees currently and you get a report negative. I can tell pre-testing itself that this morphology will be showing to be negative. So don't have to order for the molecular testing and save that 60,000 rupees itself. So what is happening? You have not only the morphology, but the molecular biology is also computed now. In addition to this, what is happening? You are doing a virtual genotyping also without even going for the genomics itself. So these are the advantages of the AI in precision medicine and personalized care treatment itself. So this comes under the group what is called as computational pathology, where we are trying to do the length and breadth, the volumes of the cells, the nucleus, all those, where we are going to calculate and predict that what goes with this patient itself.
I completely agree with you, sir. Especially in a country like ours, we have to be very, very industrious in selecting the test for the patient because of financial constraints of the patient. Also, is something that everybody has to think about. And like you said, computational pathology will predict whether you need to do the test or no in a better way. AI is also being used in biomedical research. Since you have a lot of experience in the research as well, how is AI transforming pathology research and clinical trials? And are there any areas where it's already making a measurable impact?
Okay, so if you take the clinical trials, let us group it into two ways. One is that proposals itself. Okay, so whether AI can help in proposals. See, we have lot of institutions which are funding the research as well as the clinical trials. So young junior pathologists or undergraduates wants to write a project for say ICMR, or it may be a local funding agencies which is an NGO who is keen on cancer oncology itself. They require certain documents, they require some abstracting, they require some bibliography. They want to know what is your cohort, whether it is a prospective study, what are the data you want. Absolutely, the AI is very helpful. You have to just understand what resources you have to tap on, and you will get a beautiful report generated to say that the proposal is ready. Not only that, it also says precisely how many numbers you have to include, how you have to select your volunteers, what are the blocks you have to select, what are the normals you have to select, what are the tests you have to do, and how it has to generate for the project protocol itself. In addition, it is also going to tell how many research assistants you require, what is the equipments you require, what are the reagents you require, what is the budget, how many years you're going to be, what is the total budget you are looking for. All this are given deeper by just getting onto the AI itself. Doesn't it look a miracle? A project writing which used to take months together, today takes only half an hour. And you require just to scrutinize that whether it is right or wrong, take it to your investigators and show them that this is what I have profiled it. Yes, of course, you can disclose that you have used the AI models for this. That's acceptable. So this is for helping the progenies or the followers of the research group, how they can get the advantage of the AI itself. Next is what coming to the analysis itself. How I am going to analyze the data. All the data which are there, which are captured by your Excel sheets or your personalized word processing, whatever you have got, can be just scanned, uploaded into the AI, which is going to give you a pie chart, a histogram, statistical analysis. Otherwise, you have to go in search of the statistician who has to devote the time to understand what is the p value for all your researches. So today, the data is also analyzed by the AI. The clinical trials is not only having a super robust calculators, super robust statistical packages, which a junior will also be able to analyze. Now, next, if you are having problems in analysis, the AI will also tell you how your hypothesis can be defended. So, to the research student, it helps. To the investigator, it helps. To to help in also getting a translational research from what data you have got. That is the beauty of the AI today.
So the entire cumbersome work will be taken away by AI, and we are only sitting on top of that and validating what and using the intellect to develop better research outcomes. So that is wonderful. Perhaps one of the most fascinating possibilities in AI is discovering the patterns of human perception. So, can AI perfectly entirely look at the and identify the biomarkers or disease patterns for pathologists? And do you think it will be of help or will it cause more confusion?
Yeah, we can tell very clearly by getting onto the new biomarkers and the disease patterns itself. So let us take a simple example of you visiting the laboratory every often, say 6 months, and say you are at diabetes. Now, suppose after about 2 years, you go to the same lab, the lab is going to generate a smart predictive risk analysis for you saying that there is a trend in your urine analysis which shows that you have developed proteinuria of 2 plus. With the current lipid profile, with the current LFTs, that is the liver function test, with the current CBCs, what data have got, with the ultrasonograph of your abdomen, you might probably land up in kidney failure after 10 years. So that is how the predictive risk analysis pattern has changed. So you have a predictive pattern which you are getting from your clinical laboratory data, what we are talking. Now come to that of the histopathology itself. When you're talking about the histopathology, it will tell you about the image analysis, going to tell you about the desmoplasia, the lymphocyte component, what is going to be there, whether it is good or bad. I already told you that it is going to tell you about the mitotic count. It is going to tell you about whether this morphology is totally different from the previous batch of the slides, what you have seen by the machine learning itself. So it is going to change whether it is a routine pattern or it is a very abnormal pattern, what you are seeing. Do you require any help from global consultation services itself? It will also give you a hyperlink where you can have a free consultation or a second opinion for these slides itself. So this is available today and people are utilizing it to understand the morphological patterns which are totally distinct from the ones what they usually see. Say for example, today, how many patterns you have got in the lymphomas when you look in the WHO, it's mind boggling. You look at the CNS tumors. I can't report today CNS tumors without molecular biology at all. So why? Because that's the personalized therapy what we are going to give it. And previous question answered you that how AI is going to help us in the personalization of the medicine by integrating your the radio imaging services as well as the molecular data itself. Definitely, AI has got a role in predictions, disease pattern recognition, and also getting onto the new biomarkers itself.
Thanks for that perspective, sir. As more AI products are entering the market, because now there is a sudden boom in the number of AI products that are entering. Every single person wants to develop a new AI product, and there's so much in the market. And there is also a trend that these are, some of them are biased, some of them are backed up by very good faculty, some of them are coming without much of a validation. So when AI enters a market, the pathologist should look at how to adopt AI as an AI tool perfectly. So how can they evaluate an AI system whether it is truly reliable and worthy of their trust? Because one mistaken selection of an AI product can really be detrimental for the entire laboratory. So what are your takes on that, sir?
I think there are two components. One is the clinical validation has to be done. Another one is the bias assessment has to be done. When you want to have these two pillars to be robust, you have to go for external validation itself. So when you're talking about external validation, what we mean by that, whether this tool has been thoroughly been tested on the data completely from your institution. That is very important. Different demography, whether it has any demographic parity, disparity has to be studied. A data set from a diverse patient when you're putting into the population, whether the algorithms works or not. That is important. Next is you have to have a metrics where you have a quantitation of the interpretability of the AIs, what you have been using by the pathologist itself. So when you have got three things, that is the external validation, internal validation along with external validation, Next, you have a demographic variability which you have been stabilized on it, and there is no parity on that. Then also the explanatory metrics, what you're going to get from these data are very essential for the clinical validation and the bias assessment itself. It's always better to be in a network of people who are using the AI at the national institutions where they have got repositories of the cohorts where they have studied this AI working well with the disease prediction analysis. Whether those softwares are available for you or you can access that is also important. The one today what we have and which is going easily accessible is from Tata Memorial Hospital, where you are one of the alumni there. So the computational pathology department has got the free accessibility to the head and neck cancers, as well as they are developing for the breast pathology also. That's going to be soon released on the open module where you can access it. Definitely, before adopting the AI, we have to take in mind the clinical context itself.
Thank you, sir. This naturally brings us to what are we in adapting in AI. So it is a question of training of the pathologist that I want to ask you now. Do you think every pathologist now needs to learn artificial intelligence in depth? Or do you think that the practical understandings of just the strength and limitations is good enough?
Okay, very good question. And there is a lot of options for the budding pathologists now. And also the pathologists like me, we are in transition where we are not neither there, not going forward. So first, let me take about as the primary MD when he is doing his MD or he's an young graduate. Say, let us take his less than 10 years. Knowing AI is important. He should take into consideration that AI is going to complement and enhance his diagnostic skills. And every pathologist who is going to adapt the AI in practice is going to be a bit more safer. That's what I feel. However, before you sign a report, you are liable because you have taken a decision based upon your intelligence, and AI was only a supportive tool. That is very, very important. Second thing is that if you are being a oncopathologist and you are trying to integrate the integrated diagnostics from the radio imaging as well as from the molecular pathology, it's a bit essential that you know what is computational pathology there. That becomes essential. And of course, in another 1 or 2 years, there are a lot of national institutions who are going to start fellowship courses in the computational pathology itself. And of course, I recommend on site rather than online training for all this computational pathologies itself. That's very, very important. The next thing is that you have a tech savvy. So I'll give you one example. Classical example is IIT Madras. IIT Madras, 3 years back, they started a department of computational pathology integrated with that of the medical and engineering branches, and it is called as an integrated medical engineering course. This is only 3 years old. They are trying to have MOU with lot of institutions who are having a good GCP as well as GMP, where they'll be able to understand the clinical data which can be obtained as a transparent data and also have accessible to that of the biological samples, including the tissue. So what is happening? These are branching out into MS and PhDs in integrated branch of engineering and medicine. So today, engineering who failed to appear for NEET or he did not get a medical job can join here as an MS PhD, and you have an MBBS graduate or an MD graduate here, medicine or pathology or genetics, who wants to do Python, write coding, and also make sure that is implementation. That's also possible. However, for the general pathologist, a bit of knowledge of AI is very important. This is very essential. And you cannot just enroll for AI in healthcare and get a certificate and show that you are already an AI qualified person itself. It should be pertaining to your skills and you should be able to get into the basics. So this is available as a free online course with College of American Pathologists, which has got 8 modules free of cost, and you can do it. At the end of every module, you can get a certificate.
That's wonderful, sir. I think this will enlighten a lot of pathologists to take that course because the future is adaptability towards AI. So, if there is someone beginning pathology training, let's say today, what skills should today's pathology residents develop to remain relevant and successful in AI in future? Because beyond morphology, what competencies will be next judged when they are hiring the next generation pathologists?
I think it's this question is more or less overlapping with the previous questions, and I have already told you that the resource given by the College of American Pathologists is wonderful. Actually, I have done that. So there are about 8 modules there where you can do it, which is about 2 hours each, and it is very good. Having lot of illustrations, has lot of examples which are given for the digital application of the AI imaging and also whole slide imaging there. That's one. Now, next thing is that there is a need for a hybrid medical digital skill set now. That's what I mean to the previous question when I answered. So you require to understand the basics of the AI. What are the terminologies they use? What you mean by that of machine learning? What is deep dive learning? All these are terminologies which we have to learn. It may be a bit irritating initially, but it is like adapting to our ISO 15189-2022 classes. When you started, this were jargon of words which was looking like a management articles. So similarly, I think in the AI, the language will also be like that. But once you get used to that language, you'll come to know that this is a basic which I have to understand. So the residents has to know the basic language, what they have to talk. I'm not talking that they have to know Python, they have to know this language, that language. No, not at all. This is a basic. Next is that they should get adapted to the digital workflow. What is the digital workflow? So suppose if you take today histopathology in the major institutions, it's digitalized. Starting from the specimen accession to the reporting, it has been digitalized. Compute digitalization has happened. There's a triage of cases which happens and you can report upon. So you have to work at least for about 6 months to 12 months in such training institutions where you will be understanding the digitalization of the workflow itself. That is second point. Third point is that you will become an interdisciplinarian rather than a morphologist. So this is very interesting actually, Dr. Deepa, because being only behind the microscope, you should now go beyond the microscope, where you're getting the data integrated from beyond your four walls and trying to integrate and sit in one console to say that what's going to happen to that patient in the next minute. That's how it's going to be. So the skills for the resident should be in such a way that basic, then you can go for a hybrid model, and you can also go in for that of digital workflows to be understood how you can help in making sure the computational pathology works well with you.
Now I'll move to a little different perspective, sir. So I am going to ask you what pathologist's role is in the AI development sector. So developing AI isn't something that pathologists do in isolation. So they have a robust team that is there in the entire setup. So how important is collaboration between pathologists, clinicians, data scientists, software engineers, and industry partners? Because unless all of them work together, a fantastic AI product will not come out. So, building an AI solution for patient care, what do you think is the role of a pathologist in this perspective?
Okay, so the question is very relevant and very apt. So let us go to the basic core lab where you're starting your bread butter for your what you call as your living only from the core laboratory. So when you go for the core laboratory, you have got a laboratory information system. So you want now today in the laboratory information system, what is happening to the equipment? Has the QC passed? Do you have any delta checks? Do you have any trend? So these are all the data you require sitting as an authorized signatory you want to review. Whereas other side is a person who is writing a program who is totally tangential to your thought. Okay. Then you have got a person who is a clinician who understands your problems and you understand his problem. So now you require 3 people. You require a clinician to understand his problem, what data he wants, and you want a data from the data scientist to analyze your histograms as well as the trends, what is happening. The third one is a developer itself. So you as a pathologist definitely are required to write the rules of the algorithms, which helps you in your day-to-day pattern of living in your core laboratories. Similarly, in your histopathology or cytology or molecular biology, you have to sit with two important people, the data analyst as well as the IT person who is going to write the program for you so that you know that this is the output you require. No way you can work in silo. So that is gone. Now you have to have an interdisciplinarian where you are integrating your brains with an engineering brain as well as with that of a software brain. Without these three, you cannot get into the AI module at all. It's totally difficult.
Absolutely, sir. So many regions in the world, if you see, there are so many resource shortages that you see. There are doctors, even in India, the number of doctors versus the patients and the demand for the patient care is a huge gap. So, in places like these, where there are significant shortages of trained pathologists or super specialists in pathology, can AI help bridge the gap, particularly in low resource settings? And how realistic is that vision when it comes to the challenges that you have to overcome in a resource short area?
Okay, so see, if it is hematology, if you take, okay, because hematology we have to review the peripheral smears and the bone marrows, and also sometimes the body fluids. That is one segment. The other segment is your histopathology, where you are going to report on the H&E stains and also the cytology of the FNACs or whatever you got. Now, first and foremost, you should understand very clearly that your slide should be good. That is minimum things which we require for the digitalization itself. If the slide itself is very bad, the quality of the preparation, the quality of the staining, then your digitalization will not work. Okay. Now, giving you an example, suppose you have an air bubble when you are doing a cover slipping and you push it into the digital imaging, that will be reported as malignant. Will you sign that? No, you can't because then air bubble is there. Understand? So what happens is that first we have to make sure that our basic infrastructure, the slide, the stain, the preparation should be good. So that we call as normalization. Once you have normalized it, whether it is a primary health center or a secondary health center, you can share the slides beyond the borders to get the telepathology services itself. So today, telepathology services has been anchored upon local digitalization slide system flags, which are the critical cases which has to be looked by higher officials, and the triaging is happening so that these are normals, this can be signed out. These are abnormals, which has to be signed in by an authorized person by verifying what it is. So this is the second point. Third point is that you have got what is called as critical alerts by heat map. So suppose you have got a true cut biopsy or a tiny biopsy, you have taken multiple sections. There is only a dysplasia, which is a precancerous stage, which your eye would have missed because of the eye fatigue. The AI is going to help you with. So first and foremost, normalization, triage of the cases, and it is also going to help us out in the telepathology for the heat map consultations which can happen. Definitely in India, as well as resource limited settings, the telepathology is going to help. However, it is unfortunate that in India, the telepathology services for reporting the histopathology has not brought into the regulation still. So the pending regularizations, we can expect that the digital telepathology will be like teleradiology in the short coming months itself.
Since you already mentioned about the regulatory things, I would like to dive in further on that. So, anytime technology isn't good enough unless it is backed up by a regulatory acceptance. So, how do regulatory approvals, accreditation standards, and clinical practice guidelines influence the adoption of pathology AI?
Okay, there are two things you brought into the picture. One was the regulations, another one is the compliance. Right. So let us talk now first regulatory because it is coming under the rule of the land. It could be a state or it could be central. Okay. So today when we are looking in, I have to go for the equipments which are having a CE or FDA mark. Okay, so that is very, very important. Second point is that do the product, what you're going to look in, has compliance to that what is required by certain accreditation bodies. It could be a national accreditation body or it could be an international accreditation body. So, what are the efforts which have been taken by the accreditation bodies to bring in norms for adapting the AI in laboratory medicine and pathology? That also has to be done. So, when you look at the international, we have a College of American Pathologists which has already standardization validation protocol for the laboratories and execute them to the laboratories. You can also execute. It's not that the Indian laboratories cannot execute. Indian laboratories also can go and follow the CAP guidelines for the validation protocols itself. That is very, very important. Next is that if you are using the AI framework, you have to make sure that it is coming at the amount of insurance billing codes if you are using, because you have to pay some of the AI, maybe a paid ones, and some of the softwares you might be having the paid ones. So if you want to get that, may not be applicable today, but it will be going to come. Whether you are going to use or not, you have to make sure that it is coming at the adoption of the institution adoption and the insurance reimbursement will take place there. So I think when you look into the ISO documents today, the ISO has got already two documents which have been drafted and it is under the technical committee purview now. So this is commanded as two parts. One part is the medical diagnostics and general AI practice, that is document one. Document two is specifically for the digital imaging analysis for the reporting. So when you're talking about the digital imaging, that ISO has been framed now. So probably we are expecting that this ISOs is going to get us some guidelines and make sure that the accreditation bodies also obeys that. So that's what we are expecting in the coming years.
Thank you, sir. So even when AI is involved, as you said last time, the accountability remains with the pathologist. So what legal professional responsibility continues to rest completely with the pathologist, even when AI has contributed to the diagnosis, is something I want you to talk further about.
See, whenever you use AI, the AI is going to throw you some output. Okay. Now, if you have carefully watched, even in your mobiles, when you use the chat GPTs or Meta AI, it has two emojis there. One is hands up, one is hands down. Okay. So that means you can take it or you can say this is not right. Okay. Why you're doing that? Because your brain is working there. So ultimately, the patient safety is under the prevalence and review of that of a clinician. Similarly, you being a pathologist and also a consultant to the consultant, the liability is with your brains, not with AI. So the 100% final diagnostic and legal liability is only with the pathologist who signs the report. He would have taken for the support AI, that is called as an AI decision support tool. But human in loop, which is called HIL, is very, very important to sign your reports very importantly, because you are going to decide the therapeutics and the prognosis of the patient itself. So the total professional legal responsibility is with the pathologist.
Thank you, sir. I hope all the listeners who are trying to adopt to AI and the people who are AI enthusiasts take this very seriously, because everything is, after all, the authorized signatory's responsibility. We often hear a lot of AI successes. Even if you look at adaptability of AI, if you just search in Google, you have only the successes that's written everywhere and hardly much about the failures. But it's the failures that teach us even better. So, have you encountered any situation where AI has produced some incorrect result and or a misleading report in your profession when you are trying to adopt AI? And what lessons from this would you want us pathologists to understand from these experiences?
Okay. Unfortunately, I was blessed to start using the digital imaging system for the hematology, for the urine analyzer, as well as that of the whole slide imaging right from 2019 onwards. Okay. So, what I have found out is that pros and cons both. So, first and foremost, what I found out is that I could pick up a lot of um, hematological abnormalities which my eye would have been missed. Say, for example, during the COVID time, we had at least 10 cases where the WBC showed blue green crystals of death. which I would have not heard nor seen, thinking that it's just only an artifact. But the digital imaging system for the hematology brought it out very clearly that these are blue-green crystals of death, and absolutely with the clinical outcome, these people died within 24 hours, as correlated with that of the D-dimers, PT-PTT, as well as the LDH itself. So I was 100% sure that this digital imaging system is working wonderfully well. That was one of the small example for that of this. Now, second one is that come to the whole slide imaging in the histopathology. There was caution to be observed there when the slides are not right. This I told you very clearly itself. If your slide preparation, tissue preparation, cover slipping is not right, you have a air bubble trap there. So what is this air bubble trap? When you have got air bubbles in your cover slipping, that will be flagged as malignant, high grade tumors. So you cannot report that. That is one. Second thing is that aligning of the tissues onto the slide is an art when you have a whole slide imaging. If you are not aligning the tissues properly, again you are having some paradoxical out of the range visualization which might happen. So there is a mapping which happens with that of the whole slide imaging where it happens only to this area. So the quality control, you should be knowing that this are within the purview of the slide. Example is this. If you are overloading your slide with only multiple sections, the whole slide imaging will get confused. Which area I have to focus? So that becomes a failure for you. So you should make very clearly that the protocols for your slide preparation, normalization of the stain is very important. When coming to the normalization of the stain, the quality control checks has to be beautifully adapted by your technical staff and educated by you to them. And all the artifacts has to be having to be known by both the technical staff as well as that of the pathologist. Today, what has happened, lot of people do not know the artifacts and how it is going to be rectified, including that of the staining problems also. So there are supportive literatures and books. Say, for example, there is a self-instructional histotechnology book from ACA, American Society of Clinical Pathology, which one has to have on their rack, like what you are having. Robbins as one of the Bible. This is a beautiful book, practical, applicable to day-to-day life. One. Second is that the other resource for helping you in making sure that AI failures cannot happen and your slide quality can be improved is from the College of American Pathologists. A beautiful histotechnology book, which is just a paperback, which you can have it on your rack, has also a soft copy which you can download for about $250. It's a beautiful book to say how the pathologist can armamentarium itself to get onto the beautiful slide which can be adaptable to the whole slide imaging. So AI has got what is called as failures, and sanctity and sanctity test has to be done by the one who is going to report based upon the AI itself.
Well said, sir. Building on that, should a pathologist verify before accepting an AI-assisted diagnosis? That has to happen. But what safeguards do you suggest before ensuring that the safety on routine practices maintains? For example, can you give us an arbitrary checklist, like when you are looking at an AI-assisted diagnosis, what all are the points that you check before you sign it off?
Okay. So for this, I recommend everyone to go to the CAP guidelines for whole slide imaging and adaptation to the digital pathology itself, where it gives you a beautiful SOP, how many slides you have to review, how many of the blind spots you have to review, how many pathologists have to review, and how you're going to implement the AI into the routine practice for the reporting has been given. A beautiful reference, which I'm telling is this CAP digital pathology segment itself, where they can take it. The second important thing is that visual verification has to be done at least for the minimum 200 slides, where you have got normals, abnormals, where there's a mixture of tumor, non-tumors, malignant, non-malignant, hemorrhage, blood clots, all sorts of tissues what you get in your laboratory has to be verified by the visual inspection as well as the automated whole slide imaging itself. Next is random auditing by a third person. So you may not be having the whole manpower in your institution. You might have, you may not have, but you have to call an external pathologist or an external morphologist who can audit your whole slide imaging system as well as the AI what you have adapted, so that every 6 months you are safe to understand that the machine learning is happening, the triage is happening, the algorithms have been working, and it has been validated by the third person also. Yes, of course, the compliance audit will also be there, but that depends upon the accreditation bodies. That will give you a long gap. It may be 2 years or 4 years, but it's best recommended to do a third party audits once in 6 months itself. So these are some of the places where you can start having your checklist itself. However, Deepa, once again, I'm telling, until unless your slide preparation, quality of the slides, quality of the staining is not right, your whole slide imaging as well as AI will not work. It will end up in a misery. It add chaos to chaos.
Absolutely, sir. It is always well prepared thing that tastes well. So it is similar to that. So, looking forward in near future, over the next 5 years, where do you think AI will have the biggest impact in screening, in diagnosis, in prognostication, in laboratory workflow, or is it workflow optimization, or perhaps a new area which we haven't appreciated yet?
I feel by another, say now we are in 2026, by another 2030, most of the laboratories would have gone in for AI, where they are already adopted the auto verification, the tool for making sure that 70 to 80% of the lab reports get signed off. Similarly, the adaptation will be there with the pathologist also, saying that suppose it's only a routine gallbladders or appendix where there is no pathology, you can just leave it to that of the AI to just screen this so that your high volume stacks will be reduced to only the ones which we require to do the screening for the ones which you are really required for it. This is called triaging. Okay. Then it gets into an operational optimization where you can reduce your processing times, make the automated billing process also become easy, and it's just syncs with your machines and also with that of the racks of the tissue slides what you have to see. It becomes easier. Now, in addition to this, it also gets into telepathology services. It says by itself, saying that this you might require a telepathology service, come a consultant, maybe a global consultant, or it may be a national whom you have mapped. So it becomes easier. So the next day when you come, the report is already given by the secondary consultant who has already reviewed this in the different time zones. So it collaborates with your automation of that of your laboratory itself. This definitely AI is going to bring in high velocity of the report generation, minimalization of the errors will happen, more depth dwelling by the pathologist as a clinician. So your role will change as a silo to that of a team member in a clinical management itself. That's the beauty.
Correct. Artificial intelligence is not the only advancing technology. There's something far ahead of that. So, what other emerging technology do you think will reshape pathology in the coming future? Could it be something like spatial biology, multiomics, robotics, or digital twinning, or quantum computing? Do you see any of these also entering pathology soon enough and pushing AI further?
I am viewing like this. I have seen some of the research sites where you just do a hysterectomy, and at the operational table itself, you have a machine which just scans the hysterectomy and says that I'm going to give you a 3D histology of the entire uterus, there's the tubes as well as the ovaries. So you, without doing a sectioning, without doing a staining, you will be able to analyze the histology of every segment. So you can cut like slices and you have got a 3D histology which is going to pop up. And if you have already taken and say radio imaging of this, you can collaborate with that. So that is going to be exciting. So the next one will be what is called as biomarkers, which I had already told you. You have a tissue section. I just put the tissue section under the microscope. With the help of the AI, I'm going to know that what is the predictive markers which is going to be positive for this, what are the markers which is going to be negative, What do I require to go for the genomic sequencing for this, or it is a mutant one? So that is also going to be this is an exciting emerging technologies beyond the AI itself. Next, imagine your histopathology lab. The main heart is your histotechnician, and you know very well that worldwide the microtomy is still not fully automated. It's just man and the machine there. Now, suppose you have automation, even for the microtomy by the robotics, you will say, wow, I don't have to depend upon the high skilled histotechnologists itself. So the exciting things are robotics, complete management of the histopathology and the cytology by only the robotics, where you see only the Indiran or the robots moving there and nothing to do with that of the human source there at all. So that's quite exciting. Yes, of course, the computational pathology, which I told is going to add on, but we are talking about what's going to be there after 2036. So these are the ones which is fascinating.
I can already imagine the throughput of a laboratory with all of this. So it's going to be at least 100 times more. So
But I'll be
the
very happy if I get an automated microtome where I need not have to depend upon the histotechnician. Because I'll tell you why. See, certain tissues require orientation. Say, for example, you have a bullous skin lesion, you have derma sections, you have kidney, where the skill of the technician matters a lot, and you should preserve the entire tissue what has been given, and you want the most of the tissues what has been given, what we call as a scant tissue volume. So that's the beauty.
I completely agree, sir. Sometimes the orientation and the recuts are, it's a mundane task when it comes to small biopsy, especially. You have to be very, very careful with this. Unless you have a very skilled technician, it becomes really very difficult to handle.
Yeah,
Now,
if that technician is not there, if that technician is not there, you'll not get the slide.
I will go and do microtomy that day. That's all I can
Okay,
say. Uh,
fine.
this question is for the laboratories who are inspired by our discussion now. So, if a pathology laboratory is going to begin its AI journey newly, what are the practical baby steps that you recommend first for them during this adaptation? Where should they begin, and what are the common mistakes in the beginning that they should avoid?
Okay, so first and the foremost is that they have to understand what is digitalization, what is digital pathology. Most of the problems start from understanding the terminologies itself. So digital pathology is nothing beyond whole slide imaging. If you are thinking that's a myth. The digital pathology has to be encompassed and it should be endured by everyone as adaptation of the digitalization of the hematology slides, bone marrow slides, body fluid slides, then urine sediment, stool sediment, and also the microbiology to be included, making sure that these are all the ways it looks under digitalization, because sometimes it may look totally different. One. Second thing is that go to a laboratory which has already implemented the digitalization there or the adaptation of the AI and the digital pathology there to understand the flow. That is very important. This I also told that as a resident or a PG, you have to be there for 6 to 8 months in a place where you have got a digitalization which has been there. Automation has been done. That is the second point. Third point is that you have to come back to understand the gap analysis when compared to the standards what you had seen. It could be a CAP guidelines or it could be the guidelines of the local compliance body, what is there. Do a gap analysis there. What are the things which you lack, what you want to do. Now you have to make a team. The team is not only you. You require a biomedical engineer, you require an IT person, you require a developer, and you also require a software maintenance person who is able to make sure that the cybersecurity is in place. So once all this team sings, you have to include the technical staff also there to understand that how you're going to build up the AI. So there is a need for us to understand that you have to face it out and how you have to do it. Before all this happening, the most important thing is that you have to communicate to your technical staff to say that you will not be replaced by AI, but AI is going to make your jobs more easier, have more time, to prove on that of the complex testings itself. If you don't say this, there is a huge resistance by the technical staff, junior pathologists to say that, oh, my job is going to be at stake. No, not at all. Give examples of how the routine works can be automated by simple digitalization itself, and they will be very happy to accept it. That is the first point. Second point is that tell to your colleagues that how easy it is to do a mitotic count, how easy to do a Ki61 counting, how it's easy to predict what immunohistochemistry will be positive. They'll be very excited to accept that. So give instances to the respective diverse population to say how they have to adapt. That is very, very important. Next, first do the verification as per the protocol of the CAP guidelines. Then you go with that of the implementation in again stages. So initially what you did the verification. Next, for a period of 3 months, you do both digital imaging reporting as well as glad slide review. Bring an audit. Make sure that the audit is going to give you a good mark, more than 80% you're going to pass. Then you're going to say that routinely I'm going to adopt the digital imaging and reporting in my laboratories using the AI itself. So that will give you a confidence to step out to the staircase itself. Otherwise, you're going to fall. And as I told you, if the data and the slide is not good, there will be no improvement in your process. It will be the same or it become worse.
I completely agree with you, sir. And it is also true that inter-observer variation is much lesser for mitotic counts and Ki67 when it is AI adapted. The inter-observer variation is much lesser. So that also I completely agree with you. So just as we were talking about 2036, I just wanted to ask you one more question. So what are the tasks that you want to be uniquely human only? You don't want it to go to AI in 2036. Is there any task that you want it to remain as uniquely human somewhere?
So can you just repeat the question? I was not able to understand because of the network problem.
Sir, my question is like we were speaking about 2036. So, there are some things that AI is taking up right now. So, where in the daily workflow of pathologists, which tasks do you want to remain uniquely human? And what area you already spoke about the area that AI would take up later. So, what there are some things you want to still keep it as uniquely human. So, what is your take on that?
Oh, okay. So fine. So you want to understand what's going to be the daily play card for me when I enter into the laboratory in 2035. Okay. So first and foremost is that I wish to see my dashboard. So how many slides are pending for me to review? What are the organ list we have got? So you can today channelize that and you say that, okay, you are only a kidney expert, only the kidney slides will be triaged to you. If you have a breast pathologist, only the breast pathologist, you can have that. Or if you have two or three people, it will say that so many organ specific diseases list has been there for you to know this. So these are the images I have got. These are the immunohistochemistry which we have to do. Shall I do it? So what is happening? There's a dashboard for each single case where you have the work to do list by the AI generation itself. The next one is that AI synthesis work list itself is there. So which I told you that it will generate by seeing the HND itself. These are the markers you want to do. Shall I do it? I told you that automation is already there. And if you had already given that permission, even on your mobile, even when you're at home, just go proceed with that of automation. When you come next day, the immunohistochemistry is also ready along with the AI. You need not have to go back again to the microscope. You can say that please analyze the immunohistochemistry also. So that becomes beautiful. Then next is what you want that to be reported. So there is a draft of the report which is already ready. So you have the grossing. Grossing has been done. Grossing report has been taken up. Microscopy is also there. And you also have got now to get on to that of the synoptic reports which are there for you to sign. That becomes easier. Next will be a true consultation will start now only. Because as you come, you go to the clinical meetings and you go a thing only with your mobile. Tell them that these are the data I have got. These are the treatment therapies you require to go ahead. Bringing the patient into the tumor board consultation, have a direct contact with them to show the slides. What are the radiological findings? What are the genomic findings to make sure that patient safety gets enhanced? So the consent will be like this given from the patient for the therapy. So what you have become now, as I told you from, this is the third time I'm telling, the pathologist will now truly become a consultant to consultant, and you will be the kingmaker to them, saying that what therapies you have to dictate. And you will be not sitting in your laboratory, but you will be in a clinic. So that will be your 2025. You'll be having a huge dashboard in front of you, like an LED screen, where you can see what is happening at each stage itself. So that's the beauty of 2035.
Absolutely, sir. And I can imagine how happy the patient would be if he just doesn't get a black and white sheet say, giving a pathology report, and he would actually be explained saying, this is what you have and this is what is going to be the treatment as a holistic approach. He'll be very happy to look at something like that. So
That's right.
there are so many pathologists and residents and medical students who are watching our conversation, who are both excited and perhaps little apprehensive because we spoke so much about the regulatory things and also the flip side of AI. So, what message would you like to give all of them as a part of preparation for future of pathology?
So the first message I already told, I'm reinstating, AI is not going to replace us. That's first thing. It is going to complement our brain creativity and decision making to enhance the patient safety, to bring down the errors from our side. It could be mental fatigue, brain fog, whatever you call. That is first thing. Second thing is that you have to adapt the evolution. You can't be standing in a silo and say that I not adapt. So a person who adapts to AI will win. A person who do not adopt AI will be lagging behind. He will be not be in the scene at all. Okay. Third point is that HIL is very important. Human in the loop is very important. You are professionally liable for every signature document what you're going to do. That is very, very important. More importantly is that the pathologist should be having a diverse information to adapt, including that of digitalization itself. Always remember your basics is very important. If the basics is good, the data is good, your AI works well. If any of this link is weak and you want the AI to do a great thing, it will only amplify what you already have. So AI works well when you have got transparent data, you have got a good stain slide, good integrated clinical information, validating is being done, and your AI works well. If these steps are not taken, and if it is taken and there's a weak link where you have not done strengthening there is an amplification of the chaos in your AI itself. So these are some of the final messages to the pathologists to say that pathologists still continue to sign the reports. AI is going to be only complementing to make sure that you are safe. And most important, the question what you had asked for me, which I allowed, is that who is liable for legally? Pathologist is liable legally. So do not take that AI is your enemy. Take it as a friend and make sure that you take the best out of it and make sure that you sync with the patient safety. That's all the message for my pathologist, senior, junior, and also in the transition.
Sir, thank you so much for sharing your
Thank
knowledge
you.
and experiences and insights today. It has been an incredibly informative session where the entire detail was discussed in detail. And I'm sure the audience must have gained a lot of clear understanding about where the AI stands today. And to everyone who is watching, I hope you enjoyed our conversation. And if there is any topic that you want the two of us to take up tomorrow, leave that in our comment. And again, thank you very much for sparing time for us to give such a detailed explanation of about AI. You are my mentor. You're a mentor to a lot of people. I hope there are multiple sessions in which you can enlighten us again. Thank you so much for joining, sir.
Sure. Thank you once again, Deepa. Thanks so much for the learning launch also. Thank you. Bye.
Thank you, sir. Thank you. Bye bye, sir.
Bye. Bye.